just mention that we're Bruchim Abayim B'Shem Hashem. Good evening, everybody. We have a packed night ahead. I'm sure you want to hear from the doctors a lot more than you want to hear from me. I really would like to welcome everybody to the Bikur Cholim house. Thank you so much for coming out, and hopefully everybody will be a lot more educated when they leave the room tonight. Before we begin this event, I really would like to give, I think we really owe a huge amount of hakaras hatoiv to Mrs. Chani Stefanski for getting this project off the ground, spearheading, coordinating this unbelievable event down to every single detail. On that note, I would like to thank Mrs. Tehila Mendel and Ms. Liba Lederer for making sure that every detail was done correctly. Thanks again. I would like to thank the people from Jewish Crohn's and Colitis Commission, Tzvi Yaakov Shapiro over here in Lakewood. Thank you so much for your expertise and your knowledge. And we know you're only a phone call away. Thanks again. Thanks again to Rabbi Eli Drummer. Thank you so much for coming out here. Thank you for always being available for the community that needs your help so much. I would like to call upon Dr. Lapidus, a pediatrician here in town, who is constantly available for the community, to please come up and introduce the presenting doctors tonight. Thanks again.
Thank you very much. A few years ago, my son told me a story that happened to him. He was trying to order a shirt. Now, apparently, when you're in yeshiva, it's not such a simple thing to order a shirt. Which company and how, and it's much more complicated than I could possibly understand or give over. But apparently the shirt was, and I called him before, I said, speak today, I said, Yehuda, you have to tell me how to pronounce this shirt, and he helped me. So I hope I'm pronouncing it right. It's Charles Turwitt. Okay, if I didn't get it right, then blame him, I'm sorry. So he was calling Charles Turwitt, I hope I did that, and he was speaking to them and ordering the whole shirt, and he went through everything. And at the end, after he gave his address and completed the order, the person on the other end with the British accent, which I can't imitate, so I won't even try, asked him, he said, I see you're from area code 08701, and it comes up as Lakewood, New Jersey. He said, so you live in Lakewood? And he said, yes, I live in Lakewood, and I go to school there, sure. He goes, do you mind if I ask you a little bit of a funny question? So my son said, okay, who knows what's coming now? He started to get out his Tanakh and everything just to be prepared. And he says, I have to ask you a question. He goes, we're a national company, international company. We get calls from all around the world and orders from everywhere. And we certainly get a fair share from 08701. And he said, how come it is that whenever we get a call from 08701, they always seem to know the best sale codes that are out there? I just don't understand. He goes, it doesn't take place with any other area code. I know if I get a call from 08701, they're going to know about the best sale that we currently have going. He goes, how is that possible? So when he told me this story, I was thinking about that's really what a community is. A community is not just a group of people that live together, but a community is a group of people that are there for each other. And if they have something that's good, if they have something that they feel is of benefit to somebody else, they want to share it, and they want to be helpful. They want to be there for their friends, for their neighbors, sometimes with things as mundane as sale codes on shirts, and sometimes things as serious and as life-changing as medical conditions and everything else. And that's really, we're fortunate to live in such a community. And I want to thank Bikur Cholim and everyone else who was involved in organizing not just this event, but the entire support group. It's a tremendous thing for people that have either have or know somebody that has colitis, to have a place to be able to turn to get answers, and not just from the doctors, but from people that actually have experienced it and are going through it, and be able to give them real world advice as to what their experiences are, and I hope people continue to take advantage of it. I was asked to introduce Dr. Rosh. And sometimes it's hard to introduce somebody because, you always have to say something nice no matter who they are. But fortunately with Dr. Rosh, this is not going to be too much of a problem. People ask me, I've been asked this question a few times, what's up with Dr. Rosh and his group? I don't understand it. And I asked them, what do you mean? What are you talking about? He said, I don't understand. You call Dr. Shanek's office and you call the referrals and you ask them, where should we go for orthopedics? It's a very simple answer. CHOP. Where should we go for neurology? CHOP. Where should we go for pulmonology? CHOP. All of a sudden, it comes to GI. Oh, you want to go to Morristown, to this Dr. Rosh and his group. It's not heard of. So I said, you're right. It's probably the one exception. And really, I think that exception really started from when we got to know Dr. Rosh, and it's incredible that it's actually been, this exception has been maintained through the years, that Dr. Rosh and his group are the number one go-to doctors for any and all GI-related issues. And I think the answer to that really is that there are normally three things that you look for in a doctor. And usually these things are mutually exclusive. Either you want a doctor that's going to be kind and friendly and give you time. Okay, sometimes that's the type of doctor you need. Sometimes the doctor you need is a doctor that's very involved in research and cutting edge and is going to know everything that's out there and be able to give you all your options. Okay, that's a different type of doctor. And sometimes you're going to look for a doctor that's going to be an expert diagnostician, that you're not quite sure what's going on, and you don't know exactly what the diagnosis is, and you want to go to somebody who has a name as an expert diagnostician, and that's the third type of doctor. It's incredibly rare to find all three in one doctor, and when we do find that, we usually keep him as our number one doctor. So, with that, I'd like to ask Dr. Rosh to give the first lecture. Beforehand, I've been asked to present a plaque. Doctor Appreciation Award presented to Dr. Joel Rosh. Your expertise and medical accomplishments are matched only by your genuine compassion and to every individual. Our community is deeply grateful for your ongoing support. Presented May 16th, 2017 in Lakewood, New Jersey, Evening of Education and Support, Jewish Crohn's and Colitis Support Group, and Bikur Cholim. Okay, here you go.
We'll send someone a hammer and nail tomorrow to the office.
So thank you, Dr. Lapidus. That was more than generous and gracious, and I only wish I had enough seichel to turn on my tape recorder so I could send it to my mother so she finally thinks something of me. That would have been great, but I didn't. So it's really nice to see a lot of friends, a lot of soon-to-be friends, a lot of I hope I don't have to be your friend people if you take it the right way. But it's really a very warm welcome, and I really thank you. And for those of you who need our services, that's great. And for those of you who've gotten better and don't need our services anymore, that's even better. I'll have a real pleasure to introduce Dr. Arsenescu after, but we're both really thrilled to be here. And one commercial announcement, there's a guy down on Park or whatever, Arcadi Auto Shop. Go, because he fixed my tire in record time. That's the only reason I got here, and what a mensch. The guy was unbelievable. So I'm happy to give him a plug. So in the next 4.5 hours, or I guess 20 minutes, I'll give you everything there is about IBD while I stand on one foot, to quote a famous phrase. Okay. What I'd like to do is give a broad overview when we talk about inflammatory bowel disease. What are we talking about? Our understanding of where it comes from and how we treat it medically. And then Dr. Arsenescu has some updates on nutrition and other care pathways for inflammatory bowel disease. So I think what we're going to do is we'll talk and then we'll take questions and answers, right? Is that the plan? Awesome. Okay, good. So just to make sure everyone knows the kishkas as well as Dr. Arsenescu and I do, this is basically your roadmap. You have the food tube or esophagus, leads to the stomach, which leads to the small intestine. You have many feet of small intestine and only 3 feet of large intestine. I always found that confusing, but that's because of the caliber of the tube. So small intestine is less wide, large intestine is more wide. Pretty much all the absorption, all your nutrition, all your calories, your vitamins are absorbed in the small intestine. The large intestine takes back a little bit of water, and that's what makes the stool more formed, and that's the whole story, okay? Just so that people don't get confused, doctors talk funny, and so we confuse people by the way we talk. So this irritable bowel syndrome, which 20 to 30 million Americans have, where there's not really inflammation, it's not pus and blood, it has more to do with too much sensitivity in the GI tract, some changes in the intestines, how things move through. That's very common. Less common, somewhere between 1.5 and 3 million Americans have inflammatory bowel disease. So one's IBD, one's IBS, okay? We're going to talk about IBD for the most part. I think you're going to touch on IBS, yeah? Okay, so I'm going to mostly talk about inflammatory bowel disease. So there's actual inflammation. If we look in with a scope, if we look into your intestines, we see pus, blood, inflammation. That's inflammatory bowel disease. Classically, we talk about, he's going way out of control here. There we go. So classically, we talk about two main types of inflammatory bowel disease, Crohn's and ulcerative colitis, right? Give it a few years, both terms are going to go away. It's much more complicated than just two diseases. So think of them as sort of umbrellas, and there are many different types underneath. So many types of Crohn's disease, many types of ulcerative colitis. Remember I said doctors talk funny. So this is one of the things we do to confuse people. We give it a name. What does a name do, right? It gives you some knowledge. It gives you some sense of what's going on. A woman tells you, I'm pregnant. Maybe this side of the room doesn't know exactly what they mean, but you sort of have a sense this side of the room understands it a little bit better. But we know what, I'm pregnant, I know what that means. Someone tells me they have Crohn's disease, I don't know what that means. There's so many different types. Take diabetes, I think that's a good model, right? Everyone knows there's at least two types, type 1, type 2. Maybe you know a lot about it, maybe you know a little bit about it, but at least you know there are two different types. Diabetes, my blood sugar is high. Two different types, it comes from different things, we treat it different ways. Same thing with Crohn's and ulcerative colitis. There are many different types, so we treat it different ways. There are different strategies, and probably we're going to get to a point where instead of saying Crohn's and ulcerative colitis, we're going to say inflammatory bowel disease, IBD, type 1, type 2, type 3. What are the different types? So there are over 200 genes. Everyone says, when are you going to find the gene? We already found it. We found it 200 times over. There are more than 200 genes that set you up to be able to develop inflammatory bowel disease. If there are 200 genes, there must be 200 different ways to get there, right? It's much more complicated than just one gene. When we say ulcerative colitis and Crohn's, what's the main difference between the two? So your intestine is a tube. Your immune system lives in the lining of the tube. Why? Because there's a lot of action in your intestine, right? There's a lot of bacteria. We actually have more bacteria in our bodies than human cells. We are more bacteria than we are human. Some of us even more so than some others, right? So we need our immune system there to protect us from all these bacteria. And usually the bacteria and the immune system play very nice. If I'm not wired the right way, if my genes set me up and something in the environment, we're going to talk about that, triggers it, now what my immune system does becomes poorly controlled. Think of your immune system as your army. It's what protects you from foreign invaders. Armies are supposed to follow orders. If I don't have the right orders, I go off on tangents, and that's what these diseases are. If the inflammation only stays in the lining, we call that ulcerative colitis, especially if it only stays in the large intestine. If it's able to get from the lining through the wall and into the wall of the intestine, that's Crohn's disease. And that can be anywhere from your mouth to your tush and anywhere in between. All right, so that's ulcerative colitis, Crohn's disease. The main difference being, is it just the lining or does it go into the wall? Once I get into the wall, other things can happen. As inflammation, irritation happens in the wall, it can heal with a scar. If the scars tend to tighten up on themselves. So if it tightens up, now it blocks the bowel. Now I need my friend the surgeon to take that out. If the inflammation goes through the wall, it can cause problems outside of the intestine, okay? So those are the complications of Crohn's disease that we don't want, because that's what puts you in the hospital, that's what makes you miserable, that's what needs operations. And so our treatments today are to control that inflammation. If ulcerative colitis, the lining gets too inflamed, I bleed and I bleed, there's only so much blood in the blood bank, eventually I need my colon out. 20% of people will have their colon out from ulcerative colitis. That's why we need better treatments. Both diseases, anywhere there's inflammation that I can't control, over time, a mistake is going to happen. That's called cancer. So inflammation out of control puts you at risk for cancer. So it's very important to control the inflammation of these diseases to prevent the complications. So I don't need to end up in the hospital. I don't need to see my friend the surgeon other than at the kiddush table, and we shake hands and we're nice and friendly, and that's all I need to do. But if I need professionally to see the surgeon, that's not something I want, right? So why do these diseases happen? So we talked about it. The genetics set me up. They set up my immune system that it's prone to get inflammation out of control. Something in the environment triggers it. And just take whatever you don't like about modern society. Someone has said that's what causes it. So I've seen everything from toothpaste, refrigeration, food supply, too much antibiotics, mother-in-laws, whatever. No, I like my mother-in-law. But you know what I'm saying? Stress, right? All these things people have come up with theories. They're theories. There are a couple of things we do know, which I'll show you in a minute. Genetics are very important to study, and we knew from the beginning that it's not just about the genes. Why? If I'm an identical twin, so I have exactly the same genes as my twin, 50-50. That my twin will also get inflammatory bowel disease. If it's just genes, how could it only be 50-50? It would have to be 100%. We have the same genes. Something in the environment triggered one, but not in the other. So as we understand the genes better, we'll also understand why the disease happens. So Benji Kornbluth is here tonight to talk and to talk to you if you're interested, because we know from the early days amongst Ashkenazim, there he is, wave hi to the crowd. So amongst Ashkenazim, we know there's a higher rate of these diseases, and why should that be? Well, if we study the genes in families of Ashkenazim, we'll have a much better understanding of what's going on in these diseases, especially if there's more than one family member affected. Then we could start understanding even more. So that's a very important study, and that's something each one of us, if you have inflammatory bowel disease, that you can do for all of us, because unless we study people who have the disease, we will never fully understand the disease. So that's the commercial for the genetic research and why it's so important. And a lot of what I'm going to tell you about tonight, that Dr. Arsenescu tells you about tonight, is because the people who have the disease allowed us to study and to learn more about the diseases. I told you that there are things in the environment, and what we're learning more and more is those bacteria that live in our intestine, they are a community, yeah? So like, think about I'll tell you some stories about this community. First of all, the last time I was in Lakewood, I was 3. My Uncle Murray, who won the award for the best back in Brooklyn, that's a whole nother story. He was a weightlifter, whatever. So he used to live here and used to come here to watch cartoons, I remember. It was like 3 or 4. That was the last time I was in Lakewood. The neighborhood changed a little bit since my Uncle Murray was here. That I noticed. And like I said, I'm passing by, this guy opens up his auto shop to fix my flat tire. I'll be honest, I'm telling my wife my woes, and I was in the right turn only lane, and I had to make a left turn, I realized, and there was landsmen next to me. I waved, they let me go right in front. That doesn't happen in New York, I'm telling you. So it's a very special community. But when we talk about community, all the bacteria that live in our bowel work together, yeah? So depending on which bacteria are interplaying with which bacteria, and which bacteria are interplaying with my immune system and what genes I have, that whole community is what sets me up for the inflammation. That's what we're learning. So there's a lot of of interest in the bacteria that live in our intestine, and diet probably has a lot to do with which bacteria are selected. And you're going to talk about some of that, I assume, yeah? Yeah, so I'll save that for Dr. Arsenescu. Another thing that's really interesting is where you live. So we know the further you are from the equator, the more likely you are to have inflammatory bowel disease. So some of the most highest concentrations in the United States, Buffalo, New York, and in the world, Manitoba, Canada, right? So we think maybe sunlight has something to do with it. Vitamin D you get from the sun, maybe vitamin D has something to do with it. So that's become a very hot topic. But these are observations that need to be explored further. So we talked about the different dietary triggers. Smoking is a really interesting one. If I smoke, I won't have ulcerative colitis. But if I have Crohn's disease and I smoke, it'll make my Crohn's worse. We don't prescribe smoking. It's not what we recommend, but there have been, with the nicotine patch, people have actually looked at that as a treatment for ulcerative colitis. We know certain medications, antibiotics, change what goes on in the intestine and may help lead to these problems. How do we diagnose it? At the end of the day, you take a history, you take a physical exam. Remember, there are only 5 GI symptoms, right? Abdominal pain, nausea, vomiting, diarrhea, constipation. That's it. What do? 6,843 different diseases, right? But 5 symptoms, right? So people say, oh, I'm in remission because I don't have any symptoms. I don't know if that's true. Symptoms don't always, dermatologists have it so much easier, right? You have a rash, they look at your rash. Come back next week, I'll give you this cream, I'll tell you if your rash is better. They don't ask you how many bowel movements a day you have. They don't ask you if you're having belly pain. They look at your rash. For us to look at your rash, it takes a little bit more out of you, yeah? So we try to figure out with other things, physical exam, history, but at the end of the day, we have to look at your rash. We have to look at your intestines to know what's going on. We could do that with imaging. More and more we use MRI, ultrasound, but sometimes you need good old-fashioned radiation like a CAT scan. And then we look in with a scope, and we actually look at the intestine, we look at the lining. Remember what we said before, that works great for ulcerative colitis, that's only on the lining. For Crohn's, yeah, I can look at the lining, but I also want to know if it's going into the wall. That's what radiology does for me. MRI, CAT scan, we'll look at the wall, not just the lining. So depending what we're trying to see, we may need different tests. 2/3 of adults, when they have ulcerative colitis, your large intestine starts on the right, comes across, goes down. The inflammation always starts at the end of the large intestine with ulcerative colitis and goes up as high as it goes. It's always, inflammatory bowel disease is always more severe in children than it is in adults as a rule. Kids just have a more severe form of the disease. So in kids, you see what's on the right side, the whole large intestine, 80% of the time. In adults, you see what's on the middle and all the way to the left, either just the beginning, the end of the large intestine, the rectum, or the left side. So, and the geography matters. The more bowel that's involved, the more severe the disease tends to be. So people always ask me, do I have mild, moderate, or severe? I don't know what that means, by the way. What tells you if it's mild, moderate, or severe, what's more important is how do I respond to the therapy, right? I don't care how it looks at the beginning. As long as it gets better, that's okay, right? That's what we're shooting for. So when we say more severe form, less severe form, that is one of those things. Until we can figure out IBD1, IBD2, IBD3, it's one of the things we use to help decide what is the best therapy. If I know, if I can predict, if I can prognosticate what your inflammation is going to be like, I can try to tailor the therapy better for you. So we talked about some of the complications we're trying to prevent, such as the inflammation that goes all the way through the wall and causes a hole in the bowel, then you need a surgeon to close it. Long-standing inflammation causing cancer, narrowings of the bowel. When narrowings of the bowel happen, ulcerative colitis, that's always cancer, right? Because it shouldn't narrow unless there's something in the wall. Well, the disease doesn't go in the wall, it only goes in the linings. That's a really bad thing when we see that in ulcerative colitis. In Crohn's, the disease can be in the wall, so we'll see narrowings anyway, okay? Symptoms, the symptoms are the 5 GI symptoms and symptoms that you get from inflammation. So when there's inflammation in your body, think about when you have an infection, you get fever, weight loss. These are other signs of inflammation also in inflammatory bowel disease. These conditions can inflame other parts of the body, most commonly the joints, the skin, the eyes, the liver. You can see increased rate of kidney stones, and we worry a lot about the bones. The disease itself affects the bones. So in kids, what happens if the bones are affected? You don't grow. In adults, you get osteoporosis. And so we really watch the bones very carefully. The inflammation itself, if you take and this has been done, if you take the blood from children and inject it in rats, first of all, the rat gets really annoyed, but then the rat also doesn't grow, right? So the chemical messengers of inflammation have a direct effect on bone to soften it and keep it from growing. So that's one of the ways for us as pediatric gastroenterologists, we look to see how the child is growing. That's an important sign to see if the disease is actually controlled. And some of the medicines we use, especially steroids work very quickly. They're great to get symptoms under control and then goodbye. Because the longer you stay on the steroids, the more problems you have. And also, it's been shown that steroids long-term don't control the disease, but also they cause so many side effects that they're not a good long-term treatment. We feel it takes a village to take care of someone with inflammatory bowel disease. You need emotional support. You need a surgeon, unfortunately, sometimes, good nutrition, and we're going to talk about that, and different therapies. So it really is a team effect. And we try to take care of the whole patient, try to make you feel well, but also be well. So there's short-term goals, get the inflammation under control so you don't have symptoms, but long-term goals so you don't have the complications of the disease. Just because you feel good, that's fantastic. That doesn't mean that I've controlled the inflammation well enough to stop the long-term damage to the bowel. That's what we have learned over time. It used to be, if I asked you, how do you feel, and you told me fine, that was called remission. And then later in the day, you're in the emergency room with a complication. How could that be, right? Because how you feel is fantastic, but it doesn't tell me always what's happening in your intestines. So don't be fooled by the lack of symptoms as being a sign that the inflammation is really controlled. We have found that out. Plus, people tend to be polite. You see someone on the street, you ask them how they are, they usually tell you fine. Have you ever stopped? Has anyone ever stopped? Let me tell you about my back and on my knees. And I slept fine. Who does that, right? Everyone says I'm fine, right? It's just the way we're brought up. You should expect, if you have inflammatory bowel disease, people always ask me, is my child in remission? If you're asking me, they're not, right? Remission is normal. It's normal. Everyone knows what normal is. If you haven't hit normal, you're not in remission, by definition, right? So the goal is to be normal, but not just I feel normal, but I am normal. I can do my activities. I can go to work. I could go to school. I can do whatever I need to do, and my intestines are healed and normal. Those are our goals today. So I hate this word flare. It was a terrible, terrible word. First of all, 2 minutes on history. So we call it Crohn's disease. Do you know why? So really, when it was first discovered, it was discovered by a surgeon named Ginsburg, who would operate and see this inflammation in the last part, the terminal, the end of the ileum. So if it's itis, it's inflamed. So they said the patient had terminal ileitis. If I told you had terminal ileitis, what would you think? You would think, God forbid, I've got another week. I have a terminal disease, right? So that was a bad name. We can't call it terminal ileitis. They had to come up with another name. In those days, when they published the paper, the author went in alphabetical order. C came before G, so it was Crohn, then it was Ginsburg, and then another surgeon, Oppenheimer. They needed a name. They looked at the first author, it became Crohn's disease. Terrible name. No one spells it right. We don't really know what it is, and it confuses people to make it think like it's one disease, yeah? In those days, the only thing, Ginsburg would cut it out, and when it came back, another operation, now you had no intestines left. That was a bad plan. The guy down the hall was this Dr. Crohn. He was playing with this new drug called prednisone. Do you think that would work, Dr. Crohn? It might. They gave patients prednisone, they felt better, so they wrote the paper. That was the original paper. But as we said, prednisone has too many side effects. So I would put the patient on prednisone till they came back to me begging to get off the prednisone from the side effects. Fine, I'll take you off the prednisone. And when your disease flares, come back and see me, I'll put you back on the prednisone. So that's why everyone you talk to says these are diseases that have flares and remission, flares and remission, flares and remission. It's a Bubenmeister. That's how we took care of the disease. We let it flare and remit, flare and remit, flare and remit. If you really treat it well and control the remission, you should not have symptoms, you should not flare. The other thing to realize is every time if I have inflammatory bowel disease and I have symptoms, that doesn't mean my disease is active. Right? I could have eaten something wrong. I could have some stress at work. All sorts of things can give you GI symptoms. So symptoms doesn't mean I have inflammation, and the lack of symptoms doesn't mean that I don't have inflammation. Are we good with that? If you take nothing else home, I think that's really, really important because that's so confusing, right? How I feel, I think that tells me what's happening inside. We'd like to believe that. Unfortunately, it's not that simple, okay? Dr. Arsenescu is going to tell you all about nutrition. 2 minutes on the different medicines. So we have medicines that induce, and then we have medicines that maintain a remission. Remission being defined as I've turned off the inflammation. To induce a remission, I have steroids. We've already talked about we only use them for induction. We don't like them long-term, too many side effects. And then we have medicines called the biologics, which we're going to talk about, all sorts of ones now. Especially for ulcerative colitis, we have medicines that are anti-inflammatory, open up in the large intestine, put medicine on the lining and calm it down. Those are called 5-ASA or mesalamine, all right? So that's like your aprezo, azolfidine, sulfasalazine, dipentum, pentasa, Lialda, Delzacol. Am I missing any? It's enough, right? They're all the same wine, different bottle, okay? They have the same anti-inflammatory. It releases, coats the lining. Remember, ulcerative colitis is only a disease of the lining. That works 40 to 50% of the time. We'll calm it down. And for those people with ulcerative colitis that those medicines work, that's beautiful. Because they have minimal side effects. They don't get absorbed. They really sit on the lining of the bowel, work very nicely. That works about half the time in ulcerative colitis. The other half, we need to work on your immune system to stop doing that inflammation thing. Almost always with Crohn's disease, we need to work with the immune system to stop doing that inflammation thing, okay? Those medicines are medicines we call immune modulators, things that modify the immune system. There's 6-MP and azathioprine, which are drugs we don't use in children anymore. The risk of cancer long-term with those is increased, and we have other choices nowadays. We use methotrexate, which rheumatologists have used forever. These are all that could be pills or injectable. It's once a week. And then we have the biologics, many different classes of biologics. We have medicines that we use just to take away the symptoms, just to at least, slow down the diarrhea, maybe help with the belly pain. What I always tell people is that's like banging your head against the wall, getting a headache, and taking a Tylenol, right? Better know you don't bang your head against the wall. But while you have the headache, the Tylenol feels good. So, okay, I can treat your symptoms, but I need to get to the root of the problem. So symptom relief is not enough. Some of the newer medications, so biosimilars, for a lot of technical reasons we're not going to go into tonight, biologics are antibodies that are made, they're smart bombs, right? So 6-MP, Imuran, azathioprine, methotrexate, we said all modify the immune system. We don't even really know 100% how, but we know they do. But it sort of knocks out the whole immune system. As we understand these diseases and the chemical messengers of the immune system and how they drive the inflammation, I can take an antibody and direct it to one of the chemical messengers and disable the inflammation of this particular condition. So now we have several different classes that do absolutely that. Those are called the biologics. The first were against a chemical messenger called tumor necrosis factor. So that's your Remicade, Humira, Cimzia, Simponi, all do that. These may be words you've heard. Then we have biologics like Entyvio or vedolizumab, works against the ability for inflammatory cells to cause inflammation, to move into the tissue and cause inflammation. The newest one approved this year, Stelara ustekinumab. It's Remicade is IV, Humira, Cimzia, Simponi, or I inject myself. Entyvio is IV. Stelara, the first dose is IV, the others I inject myself. Wait a minute, that sounds like chemotherapy. I get IV. What is this? This sounds like serious stuff. I think we need to, always we think of medicines as something you take by mouth. Maybe it's a cream, yeah? These fancy antibodies that directly target a part of the immune system are too large to put in a pill. That's the only reason they give an IV or self-injectable. You can't fit it in a pill, right? So sure, up until about 20 years ago, most IV medicines we think of as chemotherapy. This is not cancer. This is not chemotherapy. This is an even safer and better and smarter way to work on the immune system than the pills we had that we were using 20 years ago, like Imuran and 6-MP. So we could talk about that in the question and answer if you need. I think that's one thing that I see a lot in the office where people think, oh, that sounds so serious, it's IV. It's actually been shown to be the safer. We just have a paper that came out this week, 10-year study on Remicade, 6,000 patients around the world, no increased cancer in children. The 6-MP, however, significant increased risk in children. That's why we don't use it in children anymore. Another important thing, it's amazing. If you are on a medicine and it stays in the pill bottle, it doesn't work as well as if you take it. Is that amazing? What a chop, right? So this was a study done, this was a Snoopy Snoop. The doctor called the pharmacies to see if the patients were renewing their prescriptions. The gold are the people who didn't take it, and the blue are the people who did. And this is the people, the higher the bar, the more you were well. So the patients who were well, believe it or not, actually took their medicines. Unbelievable. But this is really important. When I tell you about those medicines that you take IV or by injectable, how much of it is actually in your blood? Because, right, if I take a pill, is it really in my blood and working? That's what taking the pill does for me, right? If you take it by injection or IV, I can measure the amount in your blood and make sure the amount is good. So that's called therapeutic drug monitoring. I can make sure you get enough that it actually works from the time you get a dose to another time you get a dose. Probably the most powerful tool we have right now. Because what we know, think about it, 2 Tylenol in the medicine cabinet, right? You could be a 90-pound little old lady. You could be a 350-pound football player. Everyone takes 2 Tylenol. It doesn't make any sense, right? But we don't have a better way to do that. We have better ways now. We can actually measure the drug and know how much is in your blood and know if it's working. Of course, we always want to weigh the risks and the benefits. Another important thing, if you come home with tonight, is we spend so much time talking about the risks of the medicines. I don't know if we talk enough about the risks of the disease, yeah? So that's why we talk about the cancer and the surgery and all the complications. Because the lawyers tell us, you better make sure you told them all the things that could go wrong, right? So you tell them everything about the medicines. I don't think we spend enough time talking about the disease. So Yashkach to every one of you for coming out tonight to learn more about the disease so you know what you're actually dealing with, right? Because that knowledge is power. So you got to know. So this was fakakta. This was crazy. We used to talk in terms of pyramid, step up, step down. Start with something mild. If that doesn't work, go to something more severe as a medicine. It's such outdated thinking. What we really do now is we personalize. We look at what type of inflammation you have and what's going to be the best medication for your type of disease. And not these crazy ideas, less severe, more severe. It should work. So now we talk about stepping in. I know what you have, and I step in and do the right thing from the start instead of waiting until you get sick and then always playing catch up. So those are the ideas I want to close with. The idea that we're changing our targets. Yes, I want when I come into the office, we know, especially in pediatrics, if you're growing and the kid's all smiling and the parent is sitting near the child, everything is good. When the kid's on one end of the room, the parent's on the other end of the room, the kid's rocking like this and he hasn't grown, I know things aren't going so well, right? So you know almost when you walk in the room about where you are, at least as far as symptoms go. But then we use more. We have blood tests, we have stool tests, we have imaging, we have scoping to really look and see how the intestine is. And those are our goals today, to really heal the intestine. So now you'll hear this term, treat to target. What is our target? A healed intestine. A well patient and a healed intestine are our targets. I think that's what I've got. So thank you for your attention. It really is my pleasure to introduce Dr. Razvan Arsenescu, spelled the usual way, right? So Razvan came to us from Ohio State 2 years ago, 3 years ago? Two, yeah. A very accomplished inflammatory bowel disease and immunology expert who takes care of adults, and it's been an absolute pleasure, and I'm sure you'll agree. Razvan.
So thank you everybody for being here. I recognize some faces in the room. I want to thank Mr. Drummer as well for giving us the opportunity to take care of patients from your community. And I hope that we're going to have a long relationship. And in a way to kind of emphasize the collaboration we have here, like we transition at the podium. In fact, we do have a program at the Morristown. And those kids that are now 18, 19-year-old, they transition actually to our IBD program for adults. And in fact, we do share a physical space in the pediatric clinic to allow parents to know us, to know what's happening when you graduate and you mature, what's going to happen when you all of a sudden show in the adult clinic. So like Joel was saying, the disease in kids is really is really more severe, but I think that we still face the same complexity. We still see these numerous manifestations of disease. So anytime you go to a talk and you look at the treatment, it's not really that everything you see on a slide or here you can apply to yourself. And the reason is that everybody's disease is very personal. And like we're going to discuss now, we're a universe. We're not necessarily human, like Joel said. We're probably more bacteria. So if you're looking for Martians, they're right here in the room, right? And because of that, you know, every kind of bacteria can interact with a specific set of cells that have some information we call genes. And then multiply that by all the events that happen to you every day, all the encounters you have with toxins and diet, right? So you get to astronomical numbers. But that tells you that the possibilities are numerous. So for that reason, your disease is different from your neighbors. And you cannot strictly apply something like a chart, right? So I think that getting the information and getting to know what's behind the scenes is actually the most important thing that you can use, not only to apply, but to discuss with your provider. Like it was shown before, you know, we have these terms Crohn's and ulcerative colitis that we are now looking into diversifying and making it even more complex and more confusing. But what I want to show you here is kind of understanding what are the players, right? So why so complex? And technically, if you think of your gut as a sandwich, right? So if you start with the cheese to the top, there'll be the inside of your bowel. And what is there? There's things floating. There are bacteria, there are bugs, and those bugs you actually get from the very first minute of life. Then you have food that is there, right? So that food also, it's like a signal. And all those bacteria and the food, they kind of are mixed together, and then they talk to the lining of your gut. And those cells that line the gut, in fact, they are the source of problems in many patients. A lot of the gene modification, the alterations we found actually have to do with how these cells actually respond to what's happening in that environment inside the body, right? Then the next kind of a layer going down, it's the part where we have a lot of immune cells. And these immune cells are trained to recognize friends and foes, right? So it's a very delicate balance here, because what people don't understand is there's no such a thing as lack of inflammation. So a little bit of inflammation, it's really like an appetizer that you take to kind of make you eat better. But in fact, the small amount of inflammation in the gut that we have on an everyday basis, it allows you to exclude those that can be potential enemies, and then only let survive those that are friends, right? But this can get out of control, and all this dialogue that happens between the food particles and the bugs and the body actually that happens to be done a storm that creates more inflammation. The other very interesting thing is, and this is something that I have been involved in research as well, is specifically to the Crohn's disease. It was found from the very early days that the fat tissue that surrounds the bowel, in fact, can be an active player. So initially we thought, well, the bowel is inflamed and it all spills over and whatever it's around is going to get diseased. But now we found out that the actual fat tissue can be a source of inflammation itself. So you can have aggression from the inside with the bugs in the diet and the altered crosstalk with the immune system, but also from the outside of the bowel with the fat part. And now we found that even in ulcerative colitis, where you don't have an obvious inflammation of that fat, the same very fat tissue can produce inflammation throughout the body and create a kind of a background where inflammation of any other autoimmune disease can be worse. So not just Crohn's or ulcerative colitis, but could be neurological, like multiple sclerosis or psoriasis, so they can all be affected by this. And in fact, like Dr. Rosh showed you that map, if you look at the map of obesities, looking at how people's body weight went up, or countries where we have more autoimmune conditions, it almost overlaps perfectly on the IBD map, right? So that tells you two things, is that there's something wrong how we eat, and the Western diet that we eat, that promotes obesity can lead to more inflammation, and also obviously something that has to do with our environment, how we actually get modernized and cleaner. In fact, we probably produce this storm that interacted with our abnormal genes. But I think that that is very important to recognize. Another important message, like Dr. Rosh was saying, is that our disease is not always in the gut. So you may think from the name that's inflammatory bowel disease. In fact, it's a whole body disease. It's an autoimmune condition. Okay? So almost any organ in the body can suffer in some way. And the more obvious ones that you may present could be eye, oral, could be bones, can be muscle, can be skin. But that's important because sometimes the non-gut inflammation can be worse than what's happening into your gut. Nevertheless, that will require treatment. And fortunately, many of the treatments that treat inflammation in the gut can actually be very helpful for those problems, maybe in different doses, but you can kill two birds with a stone in many, many cases. So I want to kind of go into the part where not necessarily showing you treatments, but showing what are the other things that would cause you to have symptoms, okay? And that's very important because like Joel said, symptoms are really overrated. And this thing with I have a flare, it can mean a million things. A flare can mean you have more active disease. A flare can be you ate something bad. A flare can be stress. A flare can be an infection, right? So we really have to go through this. And I think that, you know, many of those that have disease can recognize that at times they have no symptoms, and then a doctor does some kind of test and they find horrible ulcers, you know, situations where you're very close to surgery and having no warning symptoms. Or on the other hand, you can have a lot of symptoms, severe pain, cramps, diarrhea, and then when you look inside the scope or you do an imaging test, you find nothing, and it's mostly how the bowel functions. So I think that's very important because when you come see a doctor and you get a treatment, right, and if you're not doing better, you think, well, maybe he picked the wrong medication, maybe he doesn't understand my diagnosis. But we have to understand the limitations of the treatments. So anything that Dr. Rosh showed you, those treatments, they treat inflammation, right? They help disease go into remission and hopefully prevent complications. But if your symptoms are not a direct result of that inflammation, then we cannot have these expectations that you're going to feel better necessarily. So unless we understand and we address that, then it can be a miscommunication and really a lot of problems. So one thing that I want to start showing is that our gut and the brain, they are connected. It's really a highway that goes both ways. And one easy way to see is, for instance, when we look at patients that are in clinical trials, we see people in that part of the clinical trial they call placebo, where they really don't receive an extra medication to make them better sometimes. And we see 20, 30%, 40% even doing better. And there can be many reasons why they do that. But you know, part of that can be also because they believe that they are on treatment, they believe that they are doing better. So that, you know, power of mind over the body, it's really, really important. But the other thing to understand is that we think of the brain of being the part that has a lot of nervous cells. Our gut is really full of those nervous cells too. So the same chemicals that regulate the brain can actually regulate the function of the gut. And then by dysregulating, by having an imbalance, you can have more contractions, right? So the bowel is contracting, you get more pain. Things are circulating faster, you get diarrhea. So think of a time when you had an exam, right? Or some kind of a important event the next day, right? And you have cramps, you go to the bathroom more often, even without having IBD, right? So that tells you that all those signals that come from the brain can actually result in symptoms which may be no different from what you may have with the inflammatory bowel disease. The other very interesting thing was that many animal studies have showed that specific bugs in your gut can actually signal to the brain, and that in turn would actually modify the function of the gut. So that is very important to understand how this work together. And the important thing is to know that over half of the patients that we see have some degree of anxiety or depression. And unfortunately, many times we talk about it, this looks like a stigma, and people think, well, you think I'm crazy, it's all in my head, you don't really trust me. But we now have a lot of proof from animal studies, but even from human studies, that actual stress, anxiety, and depression it can induce inflammation of the gut. So I think that now we see treating the mind as actually part of treating inflammatory bowel disease. And it's very, very important. So many of you that will come through our clinic, you'll see that at every visit, I give you that annoying questionnaire where you have to say how you're feeling and so forth. But really, that helps us decide at what stage are you? Do you need help? You know, how much of the help you need? But we truly see that as part of your IBD treatment. It's not just Remicade or Stelara or Entyvio. You know, that is actually a very, very important piece of the treatment. And a lot of the symptoms that link to your quality of life actually are connected to making your mind better. And you know, even simple things like thinking positive, meditation actually has been found to be leading to reduce inflammation. So the next thing I want to talk about, which is actually a hot topic now in many areas of bowel conditions and even other conditions, are microbes. And like we discussed before, if you were to count the cells in your body, then you have 10 times more bacteria than human cells. And if you look at the information, the genes, that's 100 times more than you have human material, right? So that tells you of the power, what lives in your gut, and how this can actually modify how you behave or how your disease actually behaves over time. So we do many things that we take casual. No? Many patients go to doctors because they have some symptoms or runny nose or a fever and they get antibiotics. And for you, a week of antibiotics may not look big, but for those bugs in the gut, it's like a tsunami coming. And actually, people have looked, and it takes about 6 months for your gut bacteria to recover from a course of 2 weeks of antibiotics. So it's really a long-lasting effect. And during those 6 months, if you happen to have IBD, you're actually vulnerable to more inflammation. Because the way the bacteria help you is in many ways, but one of them, for instance, is to make sure that the bad guys, when they come in the gut, they don't find a cozy place, and they're kicked out. And one of those consequences is a very, very frequent cause of a flare. There's a bacteria called C. diff, which is Clostridium difficile. It's truly a difficult bacteria, but it's so common that we think that at least 1 in 5 patients that come to our office and have active symptoms that we think is from disease is actually from this bacteria, okay? And actually this can be a setback, so you can have the best IBD treatment, and sometimes because you lack this good bacteria in the gut to kind of help you, and you keep getting over this C. diff bacteria, it can set you back, and in some cases the disease may lose response to our common treatments, and you may end up actually having surgery or a bad outcome because of that. But it's very, very important to understand this, and I think that it's very important that at every of those times when we think your disease is acting up, that we actually check for it. And it doesn't stop to bacteria. There's other things that live, like viruses. We have done an analysis of records from around the country, which we published recently, and then we found out that patients that have severe disease, especially those that are admitted to the hospital, if they have been exposed to steroids or things like Joel mentioned, 6-MP, Miranda, immunomodulators, they may have high rates of a virus called CMV virus. And that virus can thrive on the same molecules that make Crohn's or ulcerative colitis active. So that activity actually invites the virus in your gut, especially if you have immunosuppression, and it can cause more inflammation, almost as severe as your original colitis. And in some patients, actually, we treated the virus and then they almost went into remission as if they had the biologic. But that's a very important thing to understand as well. The other questions obviously are, okay, so I know that I have a messed up balance of bacteria. Can I do anything about it, right? So there's several ways. One is, for instance, to help whatever grows in your gut to be better. So the same way you use nutrients to keep you going, those bacteria, they need nutrients too. And whatever you put in the gut would actually influence what lives in your gut, right? So having a diet that is rich in fiber, rich in fresh fruits and vegetables, for instance, would actually encourage bacteria that are more helpful and less leading to IBD type problems, right? So you can think of the bacteria and the food items that you have as what we call a prebiotic sort of. And then you can actually put good bacteria inside, and it's what we call probiotics. And you know, there's a billion-dollar industry, multi-billion-dollar industry in probiotics, but unfortunately, even though in animal, like in mice studies, they work fantastic, right? So you can treat colitis in mice very nicely with those probiotics. Unfortunately, it doesn't work as well in IBD, and it's not that the concept is wrong, it's that the bacteria that help us, actually, they have to somehow latch on to some degree to the lining of your gut, right? So they have to establish a community, right? It's like, you know, have people that come through a town, but it's only those that stay and build a house and belong to the community that matter. It's the same for your bacteria, right? So you can think of the probiotics more like passengers. They just walk through and they don't really establish a community. And I think that's one of the reasons. Another one is that we're also not having enough diversity in those cocktails of those bacteria, and some of them may not survive. So it's important to realize this, that, you know, there may be some benefit. I would say that probably the most benefit we see is specifically in patients that have ulcerative colitis, where the surgeon took out the entire colon and the rectum, the bottom part, and they kind of make a pouch, right, and like a new colon from the small bowel, and they attach it to the bottom side. And those people are prone to inflammation because of bacteria called pouchitis. And in those people, probably I would see the most benefit of those probiotics. In the other cases, it's really very low impact. And if somebody gets help, it's fine. But I think that we shouldn't have high hopes, especially with what we have now. I think that we are actually progressing. And a lot of the medical centers now, they're looking at making more complex cocktails and using like samples from the stool and isolating much larger and diverse communities and then putting them into pills. And hopefully that, you know, that lead to something that lives in your gut and really gives you a chance to fight, all right? And then at this point, we do this in a more crude way. So we do stool transplants, for instance, right? What is a stool transplant? So the idea is that if you lack good bacteria, you want to put them back, right? So with that in mind, you can actually harvest this bacteria by getting stool samples from healthy people, and then obviously you test them for everything you can to make sure that there's nothing transmissible like an infection. And then you can actually deliver through a colonoscopy, the same procedure that we use to diagnose colitis or inflammation in your gut, and you kind of spray that on the inside, and hopefully that actually takes residence and helps you. But at this point, there's a lot of experience with treating the C. diff bacteria, the Clostridium difficile that I mentioned. If you have that multiple times and the doctor cannot get rid of it, this is one of the best possible treatments. But there's a lot of information now coming out. Even recently, our national meeting, actually, there's more data in ulcerative colitis where this kind of intervention to modify what lives in your gut can actually lead to remission. And it kind of makes sense because, you know, in all our books and articles that we read, the first paragraph that says there is that you have IBD because the immune system has a kind of a wrong answer for the bacteria that live in your gut, right? So we know it has to do with the bacteria too, yet we do almost nothing at this point. So I think that this is really something to watch, and I think that we're also going to be involved in studies that try to understand specific connections with specific locations of bacteria to disease, but also using this as a treatment to harness the power of these bugs to make you better. The other causes of symptoms that I want to discuss, which are not uncommon, is that in patients that have surgery, for instance. So in many patients with Crohn's, the very end part of your small bowel here is removed. And what maybe you don't know is that when you eat, especially if you have fat, you got to dissolve that fat to absorb it, right? So your liver makes something called bile that comes through some small pipes into the small bowel. It kind of mixes with the fat, you absorb the fat, and whatever is left over, it ends up in the end part here, and then it goes back to the liver like a cycle, right? Now, if you cut this part of the bowel now, you cannot take in all that leftovers. And all that bile ends up in your colon, and it's like a soap. It's going to make cramps, it's going to make diarrhea, and it can make you think, oh, I have active disease, right? But in fact, you can have diarrhea from those bowel salts. And it can be easily treated with something that would suck up the salts and help you, right? And it's not uncommon that patients that had active disease, that had surgery, the bowel is gone where the disease was, and then they come back in a couple of weeks with the diarrhea, right? So we know it's probably not the Crohn's because it doesn't come that fast, and it could be this problem. The other consequences here that usually things go from top to the bottom, and then when you connect the small and the large bowel, we kind of have a gate, right? So if you remove that gate, then this bacteria can go back and forth, and things that used to live in your large bowel now can end up living in your small bowel, and they treat the food that you eat differently, which leads to more fermentation, gas, and water, and then you get the cramps, the diarrhea, and again, that's not active disease. This is an overgrowth of your normal bacteria. The other interesting thing is that the certain patients that have Crohn's and ulcerative colitis can have other genes defective that would make them get inflamed, especially in the top part of the small bowel from gluten, right? So things like wheat, barley, and rye, they have these proteins that can actually make you inflamed. So celiac sprue is a condition that we see about 3 times more common in IBD patients. So that can be another cause of having diarrhea, pain, even anemia. So many of the things that we see generically with IBD could be actually relating to this. So this should be tested as well. So next, I wanna really go to the diet. And I think that's a great topic, not just because you're interested, but also to understand that it's a lot of myth and misconception when we discuss diet. So from the studies that we have so far, we know that a diet that's rich in fruits, vegetables in a raw form is more likely to support good bacteria, is more likely to reduce the risk of cancer, and maybe associate with a lower risk of IBD. On the other hand, the Western diet is rich in fat, specifically also red meat. So red meat has been found to be more connected to inflammatory bowel disease and inflammation and even cancer, right? So these are 2 important concepts. Western diet linked to IBD, a vegetarian type or rich food in fruits, vegetables like Mediterranean diet tends to be protective, all right? Now, what you have to know as well is that many of the foods that you eat will be processed by your body, but not 100%. And whatever is left over is going to be processed by bacteria. So if you have foods that produce more fermentation, you end up with more water, there's more stretching of the bowel, more gas, more symptoms, right? So, and that's important because if you know what you eat, you can alter some of these components and you can reduce some of those symptoms, right? And so the problem is that you can use a diet that reduces symptoms by simply removing a diet that leads to fermentation, right? So you're lactose intolerant, I take the milk away from you, you're going to feel better, right? But that doesn't mean that if you have inflammatory bowel disease and you go on a diet where your symptoms disappear, it doesn't mean that we treated your disease. We just made your symptoms better. I think that's what it is. In the long term, I think that the right diet can help change the tide and push away from inflammation and reduce the risk of cancer. But I don't think it's a fix that's immediate in terms of altering inflammation, all right? So that's very, very important. I think that at this point, the way we use diet, it's mostly to reduce symptoms and increase the quality of life. But it's not a true disease-modifying agent at this point. There's research now looking at specific diets like Mediterranean diet or specific carbohydrate diets and so forth. But for the most part, the main achievement that we have, at least in the short term and medium term, is symptom improvement, okay? And you should not mistake that symptom improvement for an actual change of the disease course in that short and medium term. So, and the diets we're gonna talk about as well could have, there are different diets. So one of the very popular diets for IBS that was mentioned before is the FAAP. So FAAP stands for, it's an acronym for different kind of sugars. So the composition of your fruits and vegetables, it's always a sum of some sugars, and then they can be more or less fermentable. And that can lead to more or less gas or water and symptoms. But again, it's a symptomatic medication. In kids, for instance, there actually have been trials where what we call an elemental diet or diet that's been processed and delivered in a very basic form can help. And then there's just been evidence to decrease inflammation to some degree and improve growth. So that could be helpful. Although in adult studies, except for some Japanese studies, we have not reproduced this in the Western world. In some patients, the gut can be really affected. Either you lost a lot of it through surgery, or it's very sick that you cannot absorb nutrients, so you can receive then feeding by vein. So that's called parenteral nutrition. So it can be life-saving for some patients, but it also can be seen as a bridge in those that have surgery or are between surgeries, or they have really devastating and extensive small bowel disease. The other thing that might not come to your mind as important is, in the past, we used to have a lot of thin IBD patients, especially adults, right? But what we see now, a lot of overweight and obese IBD patients, which is kind of a paradoxical. We look at their gut, it's so inflamed, they have a lot of diarrhea, you measure some of the nutrients, they're low, yet they have, high body weight, and especially, it's not because of muscle, but it's because of fat tissue. And we now know the fat tissue is a driver for inflammation. And therefore, once somebody's in remission and we have controlled inflammation, I think that's a very important intervention where we can reduce the weight, especially through reducing the fat tissue. That in turn can lead to better outcomes. And in fact, there are studies now that connect the fat tissue to worse disease like Crohn's, more risk of surgery, or the bottom disease we call perianal disease with fistulas. It's more severe, more common in those that are overweight, for instance. In terms of the colitis that Rosh showed you, it could be a little bit in the bottom side or the whole colon. There's higher incidence of people having the whole colon involved as opposed to the bottom side if they're obese versus not obese, right? So I think that's an important problem. Now, there are some specific nutrients I want to touch upon. Most of you think of vitamin D as something that you need to have healthy bones, right? And that's not incorrect. But now we know that vitamin D is very important for immune cells. In fact, every immune cells can actually sense vitamin D around them. And vitamin D is essential to their function. And we found out now in many studies that maintaining vitamin D in an optimal dose can actually decrease the number of flares and maybe enhance the results of therapies like Remicade, Stelara, and so forth. So now we actually use vitamin D as an ally, sort of, in enhancing your chances of achieving remission. And it's important to know that, under normal conditions, you can take a small dose, tablets over the counter, something like 1,000, 2,000 units a day of vitamin D. But when you have this condition, the body is very refractory. So you need much higher dosing. We do weekly dosing, like 50,000 units, really high doses for many, many weeks. And that's important because otherwise you may be taking vitamin D every day, you think you're covered, but you may be not if you have inflammatory bowel disease. So I think that's important, as I said, for inflammation, but now we have a lot of data that even cancer actually is linked to low vitamin D over a long time. So I think that's a target for treatment too. The other very, very common part is iron. So there's many reasons that you lose iron with IBD. One is obvious loss. You have ulcers, you bleed. But the other thing is our liver makes some protein when you have inflammation, and that protein can block the absorption, for instance, of iron from your gut. So you have multiple ways to lose it. Now, what you may not know is that the iron could be good to help you, build back your bone marrow and not having anemia and so forth. But if you put iron in the gut, actually, when you have inflammation already, you can get more inflammation. And the other thing is, we found out that some of the bacteria that are linked to inflammatory bowel disease actually are helped by enhancing the iron in the gut. So we're actually doing a study now in humans, but there's a lot of data in animal studies where providing the iron by vein, first of all, is much faster. So 1 or 2 sessions of treatment could be equivalent to 6-8 months of oral iron, but it can also avoid those problems that I mentioned where you can actually enhance inflammation in your gut. So the other important thing is that iron deficiency in IBD, it's a common problem, and it's a common reason for fatigue and having lack of energy. I mean, I can tell you that almost every patient that is anemic with those symptoms, after they had their iron replenished by an IV infusion, it's like day and night. I mean, within the same day, they feel much better in terms of the energy, their appetite, their fatigue. So that's actually could be quite a game changer. The other thing I mentioned is celiac sprue in some of these patients, and the pieces of this cereals like wheat, barley, and rye can actually act like danger signals and create inflammation in the gut. So recognizing this can actually lead to improvement of symptoms too. But we also have to know that you don't have to have celiac sprue. You can be just sensitive. So it's something called gluten sensitivity, where you get symptoms like people that have celiac sprue without that inflammation part, but still you have the diarrhea and the cramps. So that's also important to know. The FAAP I mentioned before, but I want to say it again. It's very helpful to reduce symptoms in as much as 50-60% of patients have IBS, which is irritable bowel syndrome. And although IBS is different from IBD, it is not uncommon to have them together. So I think that patients that have kind of irritable bowel could be obviously because of the chronic changes and the persistent inflammation in the gut, maybe alterations of the bacteria that happen over time, but diet can actually help reduce this fermentation. And this is not a diet that I would explain to you necessarily, but I think that having a nutritionist actually to understand what you eat and having a food diary then will help design this specific diet to help your symptoms. Then overall, the main diet that we use with the idea of maybe turning the tide in terms of inflammation and cancer, I think the Mediterranean diet is probably something that it's going to be more of a routine treatment, probably with modification in the future, but I think it's a diet that you can think of in terms of lots of fresh fruits, vegetables, olive oil, nuts and seeds, unless you have problems and you cannot have them, and a lot of seafood, fish. Actually, they contain oils that are very helpful for your immune system and the healing part, and less of the red meat, like I said, that is more linked to cancer and inflammation. And again, whenever you achieve remission, I think the other goal would be to reduce the amount of fat in the body, and we know that fat and inflammation are hand in hand, and addressing this can actually make you better. The other things that you may not think about, there's a lot of evidence now that artificial sweeteners that you probably have every time you have a coffee, say, I'm not going to have sugar because I'm going to get some pounds, I'm going to get the sweetener, right? But now we know that the sweeteners actually are connected to specific bacteria that can lead to both IBD type inflammation and also obesity and diabetes. So you want to think twice when you have that. Again, we discussed high-fat diet. There's a lot of evidence, animal studies, that, and including our research, that if you combine fat with other factors, you get worse inflammation than otherwise. Many of the products you take like supplements over the counter, they have something called lecithin. Sometimes those powders with proteins that you take before or after you go to the gym, they contain lecithin, and we know that in the right environment and the right bacteria in the gut, that lecithin actually can be a food source for bad bacteria that would change the way your body processes energy, and that leads to a lot of heart disease, vascular disease, but also inflammation of the small bowel. So I want to kind of end with a couple of slides about early life, right? So I had questions before I started the talk. Somebody was asking me, so, I have IBD, maybe my wife has it, and what can I do to help decrease the risk in some way, right? So I don't think we have an answer, but we have ideas that might be helpful. So one can start with the delivery. So you can have a baby the normal way, or you can have a baby through a C-section. And why is it different? So when a baby comes out the normal way, then you're exposed to bacteria that are normally living in the gut. So you get, it's like the first impression. You get the right signal to develop your immune system, and that may be protective. Whereas in the first days of life, if you're born by a C-section, then you see bacteria that live on the skin, which is not necessarily what you want to have in the gut, right? So I guess you get this kind of a conflicting message. The other one is a simple thing as nursing. And we now know that milk is not just a food source. The breast milk is an immune therapy. It has cells of the immune system, and it has things that immune cells make. They can enhance the barrier function of your gut. It can enhance the function of immune cells in the gut, and it can make you more tolerant. Because in a way, the inflammation in the gut, it's a loss of tolerance. It's an overreaction to normal bacteria in the gut. So I think that the breast milk is a fantastic kind of a treatment, and it has been protective for many other conditions, including IBD. Research we have so far indicates that you have to nurse your baby more than 6 months to be effective. So all those studies that showed protection show that it has to be at least that amount. The other thing is, obviously, how do you start diet? So after the first year of life, when you start introducing regular diet, following the Mediterranean type of diet, it's important. The other thing we discussed were antibiotics. So we know that many times kids are sick, and some of them are overexposed to antibiotics, and I think that is something that you can take charge of, right? Or as a kid, you can live in a family where somebody smokes. So it's not that you smoke, but if somebody lives in a house with somebody smoking, the secondhand exposure actually can be a risk for Crohn's disease, right? So I think that these things are things that can modify your risk. So there's a lot of interesting research now where the mother itself can be like a vessel of health, if you will. So, whatever we eat, our bacteria process in the gut, then all those things, they get absorbed and they go to the body, so they can end up in the milk or in the blood, right? So then the baby that lives in the mother can actually be exposed to the blood to things that protect from IBD, or then after birth, like we said about a milk, that can be a source of healing and actual medicine. So I think that's something that, in terms of prevention, this is something that we have to look seriously. So I want to end up kind of repeating a bit what Joel said, but when we look at success in IBD, there are two different views. So one is your view, which obviously you come to us because you're not feeling well, you want to feel better. And then our more kind of objective way, in a way, is looking at the organ that's sick, right? So in this case, the gut is inflamed. For us, success is that we made your gut looking good, it's in remission, there's no more inflammation, right? And sometimes, as I said, because of the many things that we presented, having symptoms doesn't equal having disease. So I think that it's important that we both recognize the difference and understand what is success, what is not. But nevertheless, I think that thinking that you just come to the office and you get a pill and you get better, that's not going to happen. We have to think of diet. We have to think about making our mind right, the psychosocial problems, the anxiety, the depression, the environment modification, the smoking part, the losing weight, being active. Simple things like sleep, for instance. There's a beautiful study just published recently where it found that people that sleep 8 hours versus those that sleep 6 hours a night, those with 8 hours a night have much better bacteria in their gut, right? So that means more gut health. So it's simple things, actually. It's not rocket science that can actually prevent inflammatory bowel disease. And then I think that it takes a village to take care of an IBD patient. And really, when you choose your provider, I think you have to look at the team. A patient that has IBD doesn't belong to a surgeon. It doesn't belong to a gastroenterologist. It belongs to a team that has a gastroenterologist, has a surgeon, has a nutritionist, a psychiatrist. So really, you have to attack this disease from multiple angles because there's not one cause leading to it, right? So I think that is very important. And I think that, these relationships like we built at Morristown, where we have this transition program, where we kind of hold hands from the early life to the late life. It's really what leads to not only education and understanding, but really perpetuating this team approach to patient care. So I thank everybody. Right. So we'd probably all be open to some questions now.
So you all recognize that sleep is important. We don't want to steal yours. So we're going to take a little time to answer, because everyone comes with their question, right? So we want to make sure we get their questions answered. So if you have questions or how...
There's a few questions that you asked.
And before we start, I just want to end with Dr. Arsenescu. So I want to thank Mrs. Stefanski and Yoli Drummer for the invitation and for people giving their night seder to us to hopefully give you some education. We really appreciate that. And hopefully it was helpful to everyone. And let's get the questions or each of you go forward.
I'm not going to talk long. I just want to tell you one thing. Benji Kornblut, he's the son of Dr. Asher Kornblut, probably the future Dr. Kornblut in the long run. He's here for an important study that is going on regarding Crohn's and colitis. He has all these papers. I'm asking you, everyone, to participate. You and your family, even they're not affected by Crohn's disease or ulcerative colitis, it is very important. We have no idea as of now why I got Crohn's disease or any other of you, why we got Crohn's disease. This is an important study. They really hope that this is going to determine why we got it and hopefully how to cure it. So I'm not putting much hopes on that, but at least we should know if our children are safe, if there's anything to do to prevent our children from getting Crohn's disease. Now, I hope Dr. Rosh is going to talk a little bit more how we can prevent it. I'm not sure if you're going to give medication if my child has a certain gene.
So again, it's not one gene. What are the numbers? So we know that the risk of transfer, so if I'm a parent, what's the likelihood that my child will have inflammatory bowel disease? 8%. So God willing, you should have 100 children, and if you do, 8 of them will have inflammatory bowel disease. If you have 100 children, we could talk about your other problems. So, so it's not so likely. Keep in mind that 25% of school-age children will at some point have belly pain. So I probably see 100% of children whose parents have inflammatory bowel disease, because as soon as they get, a bellyache or diarrhea, right away you worry. And that's natural. We are actually doing several studies. There's an excellent study at Sinai that I mentioned about looking at the genetics and how this disease may come up in children and passed on through generations in multiple people. We're doing a study called GEM. So we're looking at the genetics, the environments, and the microbiome. So where we have a patient who had a child who has inflammatory bowel disease, we're following the siblings to see if there are any early signals that it's developing. So there is a lot of research in the area to better identify. Is there anything you could do to prevent? Don't have stress, don't smoke, and eat healthy. We call it, everyone wants to know what's the right diet. There's some of the questions, what's the right diet? I think we both agree there's a lot of concern about very highly processed foods. So a meat that comes out of the package onto the bread and that's a sandwich, that's what you shouldn't be eating. So if a man made it, don't eat it kind of thing. So whole foods, healthy foods, One of the questions, which was excellent, was, wait a minute, you tell me all these fruits and vegetables, every time I eat fruits and vegetables, I have symptoms. Okay, so that's what we were talking about. First of all, that may be that you have Crohn's disease and a narrowing in your bowel, because things that pass through rough, like vegetables and fruits and nuts, will really bother you if you have a narrowing. So if you keep having that kind of symptom, that's something to talk to your doctor about, to look for a stricture, to look for a narrowing. And don't forget, people who don't have inflammatory bowel disease, some foods agree with me, some foods don't. Drives my mother crazy, I can't eat beets, no borscht. You know, it doesn't agree with me, right? So it could just be a food intolerance. It could be that you have a stricture. So you need to talk to your doctor, and that's where we partner, right? The patient partners with the doctor. We need to know what's going on so we can better diagnose you. Any other thoughts about diet?
I think that, as I said, at this point, diet is a major intervention in terms of symptoms. And I think that understanding the phase of disease is also important. So if you've got active disease with a lot of inflammation, we tend to use a bland diet. So anything that's raw milk will make your symptoms worse. And then typically the healthier diet, we discussed the Mediterranean diet, is reserved once you achieve that remission. I think that's key. And then, as I said, weight loss actually is a way of altering the course of the disease probably as well.
One parent said, I see fruits and vegetables in my child's pamper. Should I worry? No, that's a normal system. So, roughage passes right through. That's why if you have a stricture, it will bother you. And if you have a baby, you'll see it in the pamper. That's okay. That's the way we're made.
So I have a question. Somebody had surgery for ulcerative colitis. Like we mentioned before, we lose your colon and rectum, and they make this pouch that's connected to the inside. And this person has inflammation of the bowel called pouchitis. So that small bowel now that became a large bowel obviously is not very happy with the situation, so it tends to react to that by becoming inflamed. So we call pouchitis because it's a pouch. Occasionally that pouchitis actually can be a misdiagnosis of Crohn's, but in some cases in most of the cases actually it's true pouchitis, meaning that it's not inflammatory bowel disease, it's just a reaction of the bowel to bacteria. And that condition actually can be easily treated with antibiotics, short courses. And like we mentioned, probiotics, that's probably the perfect setting to use a probiotic to extend the time between those flares when pouchitis happens.
And just like don't assume it's pouchitis, it really is very helpful to take a look in and see what's going on. Sometimes it's structural problems, the way the pouch was created. So these are particular surgical problems, and for folks who want to talk about that specific issue, we can stay later and talk. It's not the most common, but it's very vexing when it happens to a patient. Some questions about hormones, which the main age of diagnosis in pediatric inflammatory bowel disease is 11 and a half. 25% of people with inflammatory bowel disease will be diagnosed before age 20. So pediatrics, the diagnosis is 25%. So 75% are diagnosed between 18 and 35. There's another blip later in life. So people have looked at hormones and changes of life and puberty, and does this have anything to do with it? Not so clear that it does. I would not be concerned about it from that standpoint.
Right, so somebody's asking, somebody had Crohn's disease, it had a blockage of the small bowel a few years ago. In addition to that blockage, now that person has a narrowing at the very bottom, probably the anal, what we call anal area. And the question is, should they avoid high fibers? And then if they blend the diet and they chop it, what is better or not? So, in general, if you have a narrowing of the bowel, like with the Crohn's disease, then a lot of the diet, especially that's raw fruits and vegetables, we know that our body cannot process 100%. So a lot of the fibrous, thick material in that diet, although it's very helpful because then the bacteria in the large bowel can make products that are helpful for inflammation and cancer, in those that have a narrowing, it can form a plug, and that plug can actually partially obstruct and block that piece of the bowel. You get nausea, vomiting, a lot of cramps, right? So I think that until that narrowing is resolved, we typically recommend what's called a low residue diet, which is the point is rough, raw vegetables and fruits, with the idea that whatever is cooked and minced, probably it's less likely to form that plug that would actually block the bowel. The same would go, sometimes having popcorn, which is not 100% digested, that it's almost like a test for some people that have blockages of the small bowel. They get symptoms after having that diet. In terms of the bottom stricture, that usually is not really influenced as much by diet, because by then it's almost everything is digested as coming as a stool, as we say. But it's important that all these mechanical problems actually be addressed, and then medications have a limitation. They can treat inflammation, but once the scar set in and it's a blockage, then that requires things such as surgery. But depending on cases, if they're not very complicated, endoscopically, so with the scopes that we do diagnose disease, we can actually use balloons to stretch out and break those scars and open those blockages without surgery. So that would actually then allow somebody that had, say, a small bowel stricture to be able to eat and be able to pass those items.
Two quick research questions. You talked about all these shots and IV medicines. Aren't there any pills coming? There are. So the best thing that Remicade did was help a lot of people, but also made some billionaires. So right away, everyone wanted to get into that market and do research. So for inflammatory bowel disease, let's face it, it's America, money drives the ship. So a lot of drug companies. So there are well over 200 medications in trials now for inflammatory bowel disease. Tofacitinib, which is a pill that's used for psoriasis, will be approved probably first quarter of 2018, I suspect, or the end of this year. It's got a lot of promise. The question specifically is that better than this or that? So that was the message, right? There are different diseases, and as we get smarter, we'll know which one is better for yours. It's good to have options, right? So if what today isn't working, let's move on to something else. And if what we have today is working, don't worry about moving on, I always tell people getting on a medicine is kind of like getting married, right? You don't go into a marriage planning the divorce, God forbid, right? Sometimes we know that happens. Okay, didn't work out. But for the most part, you go in to stay. These are very effective therapies. What we don't have today are cures. We do have effective therapies. What's the difference? A cure, take this, you're done. We pray for that, all right? But until then, you take this and you'll be fine. That's an effective therapy. That's what we have today, but we're working. But you will see pills within the next year, and then there are other pills, Mongersen, 2-3 years away at least. There's a lot of promising medications coming.
So somebody's asking, has Crohn's disease, had disease for several years, it's flaring now, and then it was given options. Humira was one of the options, but also there was an alternative to going to clinical trial with a drug called Mongersen, and then they want to know whether should you do a clinical trial, should you actually do a well-established therapy or not. So I think that sometimes can be difficult to decide. Oftentimes, patients end up in a clinical study because they exhausted every known drug. It may be that they cannot tolerate an approved drug, or they may have a drug that has a specific side effect profile that would not be useful in that case. So there are also patients where they want to do a therapy, but for instance, they don't want to be long-term, and they may see a clinical study as a way of potentially getting a benefit, but not being committed for a very long time, right? So I think that it's a decision that really has to be discussed. In particular, I don't think this is something that you can answer in general. But I think that one important thing when you come at a crossroad of changing or getting a new therapy, you have to understand why are you failing, whatever you have done so far, right? So the first question is, am I having symptoms because of active disease or something else like we discussed, right? If we think it's active disease, then is this just purely inflammation? Maybe it's a mechanical problem. Do I need surgery? Do I need medicine? So I think that's important to know. But I want to say again that we should not use symptoms as our main guide to decide we have to jump from therapy to therapy. That would be really leading to losing options or getting on therapies that could be dangerous without an actual benefit.
We'll definitely finish at 9:30, and then we'll stay if people have more questions. But I don't want everyone to feel like they have to stay long. One thing that's clear from the questions: there are no doctors in the audience, because I can read every single question. It's very clear. So that's very clear. This was a great question. It ties in a lot of the themes I was saying. So I've had surgery, and I'm going to the bathroom 3 times a day. Is that normal? So again, the difference between symptoms and inflammation, it might be, there are people who have inflammatory bowel disease who go 3 times a day. It might be that it's too much. Don't forget, if you've had part of your intestines removed, it's likely you're going to go a little bit more often. Most importantly, after surgery, especially with Crohn's disease, within 6 months after surgery, you should have a colonoscopy to see if the disease is coming back. So that brings home that whole idea of symptoms are symptoms, inflammation is inflammation. You need to understand where the symptoms are coming from. And after surgery, you had surgery, that doesn't cure your Crohn's disease. It may cure your ulcerative colitis, the inflamed colon is out unless the pouch becomes inflamed, and that was that separate issue. But if the surgeon takes out the bowel that's damaged by the Crohn's disease, that's what the surgery does. All the bowel that was damaged by the Crohn's disease is out today, so you're going to feel better tomorrow, but your immune system is still your same immune system. It's going to want to attack the intestine that's left. How do we know that whatever we're doing after surgery is working to prevent that from happening? The look. All right, that's the best way. Ooh, this is for you. So a couple of questions about research. So the most hopeful research that I can tell you about is RISK and PROTECT. So RISK was funded by the Crohn's and Colitis Foundation. PROTECT is free with your tax dollars. The National Institute of Health is paying for that one. Together, you're talking about $30 million worth of research that's being done in children. RISK we started about 10 years ago, PROTECT about 5. RISK is Crohn's, PROTECT is ulcerative colitis. As we diagnose, so 1,200 kids with Crohn's disease around the country, 431 kids with ulcerative colitis around the country. As we diagnose the stool, blood, tissue, and we're looking long-term how they do, and we're figuring out different types of Crohn's disease based upon that, and different types of ulcerative colitis based upon that. So stay tuned. And if you have children who are participating in those studies, thank you very much. This is going to be the biggest kick that we get to the field this century for sure.
So I have a question asking my microbiome probiotics and people transplant we kind of addressed, but the question is also what is the research being done now and whether our center is involved in some way. So as I said, I think that harnessing the microbiome and correcting the imbalances is going to be one of the key features of treatment in the future as well. I think that the main tool at disposition now, in some crude way, are the probiotics in the use, but they're extremely limited. Activity. Those with pouchitis after colectomy for UC probably will benefit the most. The fecal transplants, in terms of research, there are several protocols now around the country. We are planning in the next 6 to 7 months to have a trial in ulcerative colitis as well as an adjunctive treatment to the biologic therapy. I think that the data that has been generated so far, it's really very encouraging. And we also had the first they end up having a stool transplant, and in over 80% of our patients, we know that their IBD actually went into remission as well. So I think that's really something that is going to be developed. There are other ways where people now are looking at making a cocktail from bacteria of the gut and putting them in pills that then open up the colon, so obviating this procedure colonoscopy as a delivery route. So I think that is a variation of what we do now, but definitely this is going to become part of the tools that we use for treatment.
All right, we'll close with the lightning round. 2 real quickies in less than 30 seconds. Someone has hyperhidrosis, very easy. Don't do steroids, control your disease, don't smoke, and exercise. Actually, weight-bearing exercise, so muscle pulling on bone strengthens the bones. Those are the best things for that. And then the last, I can't believe I forgot to mention, neither one of us mentioned calprotectin, so thank you for the question. So calprotectin is a protein that's made by inflammatory cells. So where there's inflammation, there's more calprotectin. So you could scoop a poop, send it to the lab, and see how much inflammation there is in the bowel. Fantastic idea, right? Like anything that sounds too good to be true, maybe a little bit, you have to know how to interpret it. But it's a lot easier than getting a colonoscopy every time you see the doctor, right? So it is what we call a surrogate marker. If it's very high, we know something's cooking. Maybe it's time to take a look. If it's zero, highly likely you do not have inflammation in your large intestine, less predictive about the small. So terminal ileal disease, small intestine Crohn's, may or may not bump your calprotectin a little bit. Large bowel does. So we use it. I'm sure you use it too. The real pain is $250, $300. Insurance doesn't pay for it. They'll pay us however many $1,000 to do a colonoscopy, but they won't pay $200 for the stool test. So it's very often an out-of-pocket expense, but it is a nice way to sort of screen, watch, and probably the best use is to get a calprotectin with your scope, so you can correlate what your calprotectin is when your scope is going to trend your own over time. Stay tuned, there are going to be phone apps, home tests, all sorts of ways. You can check every poop that comes out of a calprotectin with your phone. That is coming to a bathroom near you very soon. Until that happens,